Welcome to Wake Forest University Baptist Medical Center. You're just moments away from a live radiofrequency ablation of a kidney tumor. During the webcast, radiology professor Dr. Ronald Zagoria will demonstrate the minimally invasive approach to kidney tumors for those patients who may not be ideal surgical candidates. You'll also learn how radiofrequency ablation can benefit patients with less pain and faster recovery. OR Live makes it easy for you to learn more. Just click on the Request Information button on your webcast screen and open the door to informed medical care.
Good afternoon. Welcome to Wake Forest University Baptist Medical Center. My name is David Childs. I'm assistant professor here in the radiology department at Wake Forest. Today on our live broadcast, we're going to bring you a radiofrequency ablation of a kidney tumor. These minimally invasive CT-guided procedures are generally performed in patients who are unable to undergo open operative resection of tumors for various reasons, including multiple medical conditions, patients with solitary kidneys, or patients with multiple tumors in whom open nephrectomy would be a suboptimal approach. We welcome the viewers on the internet today who are joining us. We'd like to remind them that at any point, if they have any questions we can answer during the live broadcast, they may access the button live on their internet access portal, and we will encounter those questions and answer them as we're able to during our approximate hour broadcast. Performing the procedure today is Dr. Ronald Zagoria, Professor of Radiology here at Wake Forest. At this point in the broadcast, I'd like to turn it over to Dr. Zagoria so he can introduce us to the patient and bring us up to speed on where we are with our ablation.
Hi, I'm Ron Zagoria. I'm one of the radiologists here at Wake Forest University Baptist Medical Center. This patient's first name is Maddie, and she's here because she has multiple renal tumors due to an unusual syndrome predisposing her to multiple kidney tumors. Right now, I'm just completing a biopsy of the largest of these tumors. Today, we'll be ablating 3 tumors that have developed in her left kidney. As you can see, she's laying prone on this table. We have so far very light conscious sedation has been administered to her. So far, I've done scanning, chosen my site for the biopsy and ablation for the largest of these tumors, advanced a 19-gauge needle to the edge of the tumor, and done multiple fine needle aspiration biopsies with a 22-gauge needle. These are being analyzed by one of our cytologists and a cytotechnologist to give us a preliminary evaluation of this mass, and then I'll do some core biopsies, which altogether will be reviewed the next day to get a final report. Regardless of this, since due to our very high index of suspicion based on the imaging characteristics of these tumors, these will be ablated subsequent to these biopsies. So I'm going to step out and look at the microscope and see what our initial results look like. And here we have microscope set up. Have we found abnormal cells?
It's suspicious to me. I think, with the material that we'll have in alcohol fixed.
Okay. Well, I'm going to do the initial fine needle aspirations are at least suspicious for malignancy, and it's helpful if we can get a tissue type on this just to give us better information for follow-up imaging of this patient. But I'm going to do some core biopsies through this coaxial system, and we'll send those for histologic analysis with the pathologist. So we're using an automated gun. Can you take in a breath and hold it, Maddie? Okay, breathe. And this is a 20-gauge core biopsy device. And I'll transfer my core to a Telfa pad. And I'll get a second sample. Can you take in a breath and hold it? Okay, breathe. I'm going to do one more. Okay, take in a breath and hold it. Okay, breathe. Okay, and we're going to put these in formalin for fixation. Great. Now we're going to move on with the ablation. The first of these tumors is a 2-centimeter diameter lower pole solid enhancing renal mass, which will be shown to you later via slide set. And using this biopsy needle now as a somewhat of a guide, I'm going to advance my ablation probe. I've chosen a 15-centimeter long ablation probe. This is a 17-gauge probe with a 3-centimeter active tip. Can you take in a breath and hold it? And I'm going to go almost perfectly parallel to my biopsy needle. Okay, breathe. Remove the biopsy needle so that I'll be able to see where this probe is. The technique basically involves advancing this probe through the tumor with the tip at the very deep edge or just beyond the edge of the tumor. We're fortunate to have CT fluoroscopy here, so I can make fairly quick adjustments to the probe. Okay, take in a breath and hold it. The biopsy has resulted in a little bit of bleeding around the kidney, but I think the tumor is visible. Okay, take in a breath and hold it. Okay, that's okay. And once again, take in a breath and hold it. Okay, breathe. Okay, take in a breath and hold it. And I'm just making rapid adjustments to try to localize, get the tip into the tumor. Okay, take in a breath and hold it. Okay, breathe. I think I'm a little bit cephalad to the tumor at this point. Okay, take in a breath and hold it. So make an adjustment. Sorry. Okay. Jason, you want to give her some more sedation? Okay, take in a breath and hold it. Okay, breathe.
You'll notice each time that Dr. Zagori has the patient take a breath in. That's because as the patient breathes in and out, the diaphragm actually moves the kidney
Take in a
slightly
breath and
up
hold
and
it.
down.
Give you some more medicine right now, okay?
Okay, breathe. Okay, now we're getting very close. No, you're perfect. Okay, take in a breath and hold it. Okay, breathe. Okay, take in a breath and hold it. Keep holding. Okay, breathe. Okay, that's fine. Go ahead and take in a breath and hold it. And breathe. Okay, take in a breath and hold it. Okay, breathe. And we're just now puncturing the tumor. Okay, take in a breath and hold it. Okay, breathe. Doing great. Okay, take in a breath and hold it. Okay, breathe. Okay, now it looks like I've bisected the tumor. It's hard to see the tumor, and we had to use landmarks, but it looks like we've now punctured this 2-centimeter tumor. What we'll do is I'm going to start the ablation, and we're also going to do some scans. These are fluoroscopy images. Let's go ahead and start. We'll set this for an 8-minute ablation. Jason, before we turn on, let's give her a little bit more medicine. And can we do a Z10 at 250? We can go ahead. Let's go ahead and do it first, and then we'll. So we're going to get a little scan here. The fluoroscopy images are low resolution images, so they're low radiation, and it's a little bit harder to see the fine detail that we can see on a regular scan. So we're going to step out and do a limited scan just centered on the area of the probe to, again, just more clearly see the lesion. Again, these can be obscured a little bit by hemorrhage around the tumor, but a benefit of that in this case is that it's moved the tumor away from the psoas muscle, which contains the genitofemoral nerve, and that is a concern for us. So we had intended to inject some fluid there to push the kidney away, but that's become unnecessary. And so now we're generating a little bit higher resolution standard scan through that area. And again, it's very important to have good landmarks about where the tumor is located in the kidney. There's a little bit of hemorrhage around the kidney, and it looks to me like we've bisected that. I'm going to pull back just a tiny bit. The tip is at just beyond the deep edge of that. Okay, and that is at 238.
The ablation zone doesn't go very far at all beyond the tip of the actual probe, so that we want the probe basically to be at the deep edge of the tumor margin when it's being placed. If we can go to the PowerPoint slides, I can demonstrate.
Maybe 1 second, and we'll turn on
okay.
Okay, let's start the ablation. So now we're using a water-cooled ablation device. We turn this on impedance control, which is sort of the standard setting that does autopilot. This device, the water cooling and the pulsation setup of this allow you to get a larger ablation zone. The water cooling cools the temperature of the area immediately around the exposed portion of this antenna. There's the final 3 centimeter tip of this is exposed. It emits the radio frequency energy, allowing for a large generation of a large volume of heat. The heat generated can be so large that it can cause boiling and charring of the tissue, which prevents penetration of the energy beyond just the immediate area around the probe. And we want to prevent that because we would like to get about a 2 centimeter to 3 centimeter area of ablation around the probe tip. In order to counteract that high concentration of energy, they use 2 techniques, the cooling of the probe and the pulsation energy. The pulsation energy, basically the box monitors the impedance of the tissue around the probe tip. If that impedance rises rapidly, that indicates boiling and charring and overheating in that area, again, which will inhibit further ablation. So the device then goes off for about 20 seconds, lets the area cool off, and then powers up again to continue ablation. And we set for a maximum of 8 minutes for these small kidney tumors. We may shorten that if we start getting high impedance levels. Okay, go ahead, David.
Okay. We're just going to go to the PowerPoint to show some of the pre-procedure imaging that we have on the patient here today. You'll notice on the far left the lesion pointed out by the orange arrow here is currently the lesion in which we have placed the probe. That's the largest lesion and will be the first to be ablated. That was the biopsy site, the thought being that the largest tumor would yield the highest diagnostic yield. The middle image, as you can see here, demonstrates a much smaller, more subtle lesion and the lateral aspect of the interpolar kidney. And then there's also a very small lesion at the top of the kidney as well. All 3 of these are going to be targeted on today's ablation. The patient actually did have another lesion in the right kidney, but we're going to save that for a different date after the patient's fully recovered from these 3 RFAs.
Maddie, you're doing great. How do you feel? Okay. If she's feeling some pain, we're going to give a little bit more concentration. We use fentanyl and Versed. Again, the ablations go fairly rapidly, so we're already 2 minutes into this, and this has been rolling off, meaning it's reached those high impedance rises quickly. And during the turn-off phase, there's very little ablation. So once we get repeated roll-offs, impedance roll-offs, then we usually discontinue this after a minimum of about 4 minutes. So we're going to do a 4-minute ablation and then move the probe. With tumors that are larger than a centimeter or so, it's advisable, in my opinion, to do multiple overlapping ablations. So I'll do at least 2 ablations on this 2 centimeter lesion. No, you need to be quite still. We'll give you some more sedation, though. How much have you given so far?
250.
Okay, so we've given 5 milligrams of Versed.
While we're waiting for this to proceed, let's start answering and addressing some of the questions that have already come in from our internet audience. The first question states, I have a small 2.4 centimeter tumor on my right kidney. It is located in the kidney and the artery feeding it. Could this be a candidate for radioablation of the tumor? I would like to avoid kidney removal if possible. And that's more and more patients we do see referred to patients that aren't interested in surgical repair or removal of the kidney. In this size tumor, 2.4 centimeters, we've had outstanding luck. Dr. Zagori has published one of the largest case series addressing this size tumor. And what we found is that the tumors that are 3.7 centimeters and less, we've had 100% eradication of the tumor at follow-up. We have successfully treated larger tumors, but this size tumor, as this patient here is reporting, we've done quite well with a near 100% successful eradication at follow-up.
It is important for all patients who have these tumors, I think this is Dr. Zagori again, to be evaluated by a urologist who's an expert in renal tumors, as surgery is still the standard of care for these, particularly if the tumor has spread into a blood vessel. it would not be amenable to this technique. But the urologists in this community are very familiar with this procedure, and this is where the referrals come from, but it is wise to be evaluated first by them. So now we've finished our 4-minute ablation, turned off the water cooling, and we're getting a temperature in the tumor itself, and the readout is 73 degrees Celsius. The lethal temperature is anything above 50 degrees Celsius, so we've got very adequate ablation, at least in the area immediately around the probe. So now I'm going to pull back a little bit and reposition slightly more medially to get the more medial edge of this tumor. Okay, Maddie, taking a breath and hold it. Okay, I think she's asleep now, so I'm going to just pull back and move. Okay, and then I'm going to rescan. Now the position may change a little bit because she's now asleep. And will not be able to help us with the breathing, which is fine. Okay. And I'm just doing fluoroscopy to work my way up to the tip of the needle. And there's already quite a bit of visible change in this tumor, but I'm going to try to locate a little bit more lateral out into the renal parenchyma. Just by a few millimeters is all we need to get a slightly different ablation zone. That looks good. And I think we're good there. Okay, let's do another 4-minute ablation right there. And then I think I'll do one slightly more medial closer to the psoas, and we'll be done with this tumor. Yes?
Again, here's the needle tip again, the deep edge of the lesion. If we could now, we could address another of the questions that's come in from the audience while we're waiting for the next ablation. Question is stated, in the kidney ablation procedure, how successful is this form of treatment in children under 12 years of age? How frequently can the procedure be performed if an additional treatment is needed? And what, if any, would be the long-term adverse effects expected for the patient? There's really very little data looking at pediatric patients for ablation. Other lesions, bone lesions in particular, such as osteoid osteoma, have a lot more number of patients and a lot more patient series objectively looking at the data. That being said, it would obviously have to come through a pediatric urologist who could assess the patient and to help determine how appropriate it would be for a percutaneous versus a surgical repair in such a patient. It's an interesting point about additional treatment is needed. In some of the larger lesions, we've noticed that as the lesion gets larger, there's a little higher chance of residual viable tumor to be left after a single ablation. The good news is that many patients have been successfully retreated. That is, in a subsequent treatment session, the areas that look like they may be viable tumor on imaging were retreated, and many of those patients went on to have long-term survival in excellent range in 90%. So retreatment is a possibility if needed. As far as adverse effects long-term, we found that most patients, as far as renal function, tolerate the procedure quite well. Even patients with a single kidney that undergo ablation for a tumor only expect about a 13% worsening of renal function, which often improves over a year or two period. So there's very little effect overall on kidney function.
Meanwhile, while we're doing this ablation, I'm starting to pick my site for the second tumor, and I'm doing that by landmarks that I've identified within the kidney. Well, we're doing that ablation. It's a little bit uncomfortable. Just try to be real still. Okay. Okay, we're about 2 minutes into the second 4-minute ablation.
We'd also like to invite the audience currently, if they have any questions, again, you can submit those by pressing the MDirect Access button on their Internet Access portal, and we'd be happy to answer those.
And it looks like the tumor has, it's very difficult to see where the tumor was, in that it looks like it's been pretty much obliterated already, but
Doing, Manny? Feeling okay?
At this point in the procedure, Dr. Zagoria is going to be looking at other areas for ablation. That'll involve basically repositioning the probe into the other tumor foci to proceed with those ablations. We'll see how the temperature looks at the end of this cycle.
so we now turned off the water cooling system, and we're just measuring the temperature inside the tumor. Okay, and we've got a temperature of 69. See if it'll. Okay, 70 degrees Celsius. I'm going to do one more ablation in this area, just a little bit more caudal. Okay, just stop breathing. Okay, breathe. Pull back just a tiny bit and see how our position is. Okay, stop breathing. Okay, breathe. And this looks like a good position in the lower part of the tumor. Go just a little bit deeper. Okay, let's do set this for 4 minutes, and let's do another scan right there. So, and make it a little bit bigger area so I can see where the next tumor will be. I'm at 248. Okay, we're going to do another little scan of the kidney area to help pick the next site.
The fluoroscopic guidance provides great near real-time guidance for motion and micromotion of the needle, but for larger volumes of tissue, oftentimes a real actual CT scan gives us better resolution and gives us a more three-dimensional look at the kidney, especially for when we're moving the needle over large distances.
And you can do the scans while you're doing the ablation with this particular device. It doesn't lead to artifact, or significant artifact anyway. Okay, we're now reconstructing the scans. We're going to evaluate those. Jason, you can go back in. Okay, go back down to the... Okay, come back up now. Okay, right there. Okay, come back up. A little bit farther. Okay, keep going. Keep going. Okay, go back down. Go back down, go back down, go back down. Okay, right there. Okay, so go back up one. Okay, so I think that'll be a good position for my next. Okay, this will be the final ablation for this lesion, then I'm going to move on to the next lesion. There's that 238.
Okay.
Can you show me the original PowerPoint with the scan, with her scans
Yes,
on?
certainly.
Okay. So I think that is. Okay.
You'll notice there's some
These
air
other
droplets
lesions are. I'm going to squeeze behind you. Don't move.
air droplets that have gathered around the ablation site, and that's normal with the tissue necrosis that occurs with the ablation as it progresses.
Yes, you can.
And I'm going to give you some more numbing medicine back in a different place now.
While we're setting up for the next ablation, I'd also like to
more lidocaine. And I'll check this position with fluoroscopy. I'm going to go back and check the scans again. Dave, will you help me localize where this other lesion is?
Yes.
Let's go back to these are the originals. Let's look at those up more towards the upper pole. These are very small tumors, the second two, so they really have no contour deformity. Okay, go down a little bit. This, the top one is right there, but let's go down. Okay, keep going. Right, I think it's yes, right there. Okay. Okay. So I think this is that little divot there. Do you agree? Okay, we finished our last ablation on this one. And we've reached 70 degrees Celsius. Now at the end of each of these ablations, we're going to do cauterize the tract. So I'm going to pull back 3 centimeters, which we've already destroyed. Okay, can we do one tract cautery before I take out this probe to kill any cells that may be along the tract and possibly to decrease the bleeding. Okay, I'm going to withdraw the probe. We've finished the ablation of the largest tumor. And now I'm going to move on to the second. Okay, that looks like a good location where my marking needle is. Get a little bit more lidocaine.
So typically we'll use a small lidocaine type needle to mark an appropriate skin entry site. We can see that quite well in the CT images. It allows us to have an appropriate skin entry site on subsequent ablation probe placements.
Okay, we'll utilize the same probe through a different skin site. And I'll place the probe part of the way to near the kidney. Attach the tubing to this sterile sheet. A little clamp to loosely hold it there. And then image this area and can adjust my position then. Okay. And there we see looks like I'm heading in the perfect direction here. So I'm going to create a little more slack here, aim a little bit towards the feet, and advance a little, scan. I'm going to advance farther. It looks like I'm going in the right direction. Okay, Excellent. And we should be protected from the kidney by the renal parenchyma there. The colon should be far enough away. Trying to go right to the indentation in the renal parenchyma. Okay, let's do an ablation right there.
Typically, if we can keep the bowel and other structures about a centimeter out from our ablation zone, we've had excellent results and a safety margin for those. While we're getting underway with the ablation, we had some technical issues with the microphone, so I'd like to address one of the questions that came in over the internet. That was, do you have experience with this procedure for small peripheral liver lesions, 1.2 to 1.5 centimeters in size? And RFA, the earliest cases were actually from colorectal metastases in the liver, and there were many studies looking at those patients which had quite good outcomes. We perform those type procedures here as well and have for some years, so we have quite a bit of experience in both primary and metastatic liver lesions. Of course, it has to be put into the clinical scenario as to disease status in other parts of the body to decide who is an appropriate candidate for such treatment, but technically, yes, we quite a bit of experience with those liver lesions and perform those with some frequency here.
And meanwhile, while this ablation is ongoing, I'm going to position finding a location to do the third and final ablation. You're doing great. We're almost done. While that's ongoing, Maddie, I'm going to give you a little more lidocaine. Actually, I need to draw up a little more lidocaine.
While he's doing that, I'll come back to another question that's quite interesting, and that is, what is the percentage of recurrence with this treatment? And as I alluded to previously, Dr. Zagori has published a large case series looking at this very question, is oncologic efficacy of RFA for renal cell carcinoma. For smaller lesions, the results are quite excellent. For lesions that were 3.7 centimeters and below, single treatment, single session therapy resulted in about 100% efficacy as far as no evidence of tumor on follow-up imaging. As far as larger tumors, including all comers, even a patient up to 8.8 centimeters in size, it was more like about 93% for disease-free survival at follow-up. So for all comers, the percentage of recurrence has been quite low, and for the lesions 3.7 centimeters or smaller, they've been nearly 100%. This compares favorably with other studies that have showed results anywhere from 80 to 90% up to 100%. So we would expect an average of all those studies somewhere in the low to mid 90% tumor eradication without evidence of residual recurrent disease. This is relatively new as far as maybe 6 to 7 years old. So there's going to be some more long-term data that we look forward to publishing to look at outcomes out to about 5 years out, which is sort of the benchmark for therapy and oncologic treatment. And we look forward to seeing those results. But in the short interval, we've had excellent results with very low recurrent rates.
We've been treated over 400 patients with renal tumors using this technique since the year 2000, and we have had a small number of recurrences, usually with larger tumors. These have been generally just treated with additional ablations and have led to adequate results. The pain experience with these is quite variable. Maddie's feeling a good bit of this pain sensation from this procedure, but we're just about done with the second ablation, with destroying the second tumor. And compared to the discomfort with surgery, it certainly is minimal.
Typically, most of the pain is just soon after the procedure, and that typically tapers pretty well within a few hours, and most people are left with just sort of a soreness in the flank by the afternoon, evening hours, which becomes kind of a more dull, kind of a musculoskeletal type pain within the days that follow. But most patients are able to resume pretty normal activity the following day.
And we finished this ablation of this second tumor.
So we're going to look at the end temperature for this next ablation cycle here.
And this tumor is a little bit more deep in the parenchyma, so it may not be as high temperatures, but it looks like we're going to reach the lethal temperatures desired of 50 degrees or above. Okay, let's go ahead and do the tract cautery.
Cauterization is a fairly simple procedure. We simply retract the probe back approximately 3 centimeters along our entry tract, take the temperature up to approximately 90 degrees Celsius.
And there's virtually been no bleeding so far with this procedure. Okay, just relax now. You have to lie back down.
Can you lay back down for me, Maddie? Can you lay down? There you go. Come on, there you go. Perfect.
And this lesion, we're basically trying to get in the proximity of this last tumor.
No, it's okay. We got you.
And I've already numbed up this area. Okay, stop breathing for a moment. I'm going to go intercostal with this probe. Okay, go ahead and breathe normal.
The probes are quite small in this case, and it gives us some flexibility for placement. We're able to go between the ribs, under the ribs, and in between bony structures, so it's a pretty versatile system.
We're just going to reposition our arms here for a little bit more comfort. Okay. Check my position with fluoro. Probe tip is heading towards the upper pole. Want to be more medial and cephalad. Reposition a little bit more. You're doing great. Just try to be still. Get back down. Put your arms back down. You're moving a little bit too much.
I understand. I'm sorry. Please forgive me.
Okay. Remove this clamp. Reposition this a little bit more dramatically towards her psoas muscle. Okay, that's much better. Okay, be still. Yeah, we're almost done. You just have to find the needle tip. Okay. Excellent. A little bit too cephalad to the lesion. And I'm watching the monitor to locate this.
Mm-hmm.
Okay. I'm going to advance this right to the edge of the cortex. Okay, let's do an ablation there, and let's do another scan there too, please. Okay, so I've now positioned the probe in the area of the most cephalad tiny tumor. Let's do a 4-minute ablation there.
Okay, here we go.
And do a scan of that area centered on 214.
While we're setting that up, I'd like to get back to some of the questions that have come in from our audience. This is a good one here. It states, are there any ablation options for larger tumors? And as I said, larger tumors have been successfully treated with RFA. There's some data in the literature to suggest that cryoablation, which uses freezing temperatures rather than heating temperatures to treat tumors, may be better for larger tumors. We've treated lesions that are quite large with the cryoablation. In that procedure, basically what happens is it's a probe, much like we're seeing today, a metal probe, but instead of emitting radiofrequency waves and heating, it causes a large ice ball to form around the edge of the probe, and that ice ball actually encompasses and kills the tumor as it forms. There's a newer therapy also that's come on the market recently known as microwave ablation, and it's similar or the same technology as basically a microwave oven. The microwaves in this case are emitted from the probe, and the probe is a similar size to the probe you're seeing today. And again, that uses heating energy from the microwaves, and there's some evidence that that may be efficacious in larger tumors as well. So some of the ablation technologies are thought to be better suited to different sizes, but that's still investigational at this point, things that we're looking into. And the question here, is the size the only criteria for exclusion using this technique? And obviously size is quite important. Once a tumor becomes very, very large, it's difficult to get a complete ablation percutaneously, either with the cryoablation or with the heat, be it from RFA or from microwave. There are other criteria, as Dr. Zagori alluded to. If a tumor is growing into the renal vein, or if a tumor were invading into adjacent vital structures, those may be reasons not to treat with ablation. In addition, if there are tumor in other areas, parts of the body, if the tumor has spread hematogenously, the patient may not be a candidate. So there's a lot of criteria to look at. Size is one of the most important, but there are certainly others that we have to take into account when we decide which patients are appropriate. Again, we work in close consultation with our urology service here to try to give the best treatment options for the patients that we see. There's another question here that asks, how do you know how long to ablate? Well, we sort of had a standard, and a lot of the treatment links were often based on models from the liver. Obviously, the kidney is not the liver, so we have to make slight adjustments. Typically, what we're looking for is an end treatment temperature of 50 degrees or greater. And as Dr. Zagori said, at 50 degrees, cell membranes break down, and cell death or apoptosis occurs in the tumor. So we're oftentimes looking for that temperature at the end. That being said, as far as what we do here locally, we try to do 6 to 8 minute ablations. Oftentimes, we can do as short as 4 minutes. Much of it depends on the impedance. As Dr. Zagori was explaining, if the impedance is met and there's a lot of resistance, oftentimes the system rolls off or basically turns off for a period of a few seconds to allow the area to cool. When that happens, we're not really delivering any heat energy to the tumor at that point. So if we're in a situation where the resistance is so high we're not delivering much energy, there's not much need to continue on for much longer. So we start with a goal of anywhere from 6 to 8 minutes per ablation, but we tailor that depending on what we're seeing as far as resistance and of course how our end temperature looks at the end of the ablation cycle.
Okay, we're going to 4-minute ablation on this upper lesion.
Okay.
This, be still. We're almost done.
Hold what you got, okay? Stay in position for me.
I think what we're going to do at this point, since the targeting looks like it's been adequate and we've gotten good lethal temperatures, is we're going to take out the probe and do a contrast enhanced study to assess the results, and then we, if needs be, can do additional ablations. We've adequately exceeded the lethal temperature. Can we do one more track cautery? Reach almost 60 degrees here. Okay, I'm going to pull back 3. Okay.
Ready?
Yep. So we then do not use the water cooling for this point. Just heat the tract up to 90 degrees Celsius, which is obviously enough to kill any viable cells that might be there. I'm going to take the probe out. Okay, now just be still. We're about done.
Maddie, hold still, sweetie. Hang on, I've got to take some more pictures.
So at this point,
okay?
all the probes and equipment have been withdrawn. We're going to do a CT scan, basically a diagnostic scan, first without contrast to look for any areas of hemorrhage or areas that are intrinsically hyperdense. Then we'll repeat that with contrast enhancement, both at 60 seconds and at 120 seconds. That lets us look for both complications such as active bleeding, but more importantly, it shows us if there's any residual enhancement in the tumor. What we found from our previous experiences, if there's any residual enhancement, there's likely some residual tumor there. In cases where we have not seen enhancement, in the tumor itself, it's been very accurate in determining that there is no viable tumor there. And those patients uniformly had no evidence of disease at follow-up. So we'll get going with that scan here in just a few minutes. Another question that's come in as well today is asking about the rate of perinephric, meaning next to the kidney, or retroperitoneal hemorrhage, and what is the rate of abscess collection post-procedure. And looking at our experience here at Wake Forest, the rate of perinephric hemorrhage or hematoma has been quite low. Only one patient of about 106 actually required any blood transfusion. No patients required any operative or embolic intervention. So even though there is maybe some small hemorrhage, which we had a small amount of at the beginning of the procedure, it's never really been of much clinical significance. As I said, just 1 out of about 106 patients where it really became relevant. Abscesses have been reported post-RFA. We've had just one, so it's quite rare. The tissue is devitalized, so there is some risk of seeding, but it's just not a complication we run across with any real frequency.
There's always some perinephric hemorrhage from this procedure. In this case, it looked like most of the hemorrhage actually occurred from the biopsy, which is, again, thought to be less invasive than this. But it is uncommon for people to continue to bleed and require transfusion. Again, as Dr. Child said, in our study of complications in 125 tumors and I think 106 patients, we had one patient that required a transfusion. And since then, we've had a couple of others out of the total of about 400, slightly more than 400 patients. Serious complications are rare. The main, most dreaded complication is a stricture that can develop near the ureteropelvic junction. The ureter is sensitive to the ablation just as other viable tissues are. So in cases where the tumor is very close to the ureter, we then would ask our urologist to put in an end-hole stent, which we would then infuse with cold water during the ablation procedure to protect that. And so far in small series and in our experience, this has been effective in protecting the ureter from developing a stricture. If a stricture does develop, it will likely be permanent and not be responsive to any other kind of medical management or interventional procedures.
Yeah. And again, this kind of underlies the importance of working closely with urology, really the kind of the expert in surgical management of the kidney. They certainly assist us quite a bit with placing those stents and working closely with us and following these patients post-procedure.
So at this point now, we're going to get a new baseline scan immediately after we have now finished the ablations. And then this will serve as our baseline once we've given the contrast material. And there certainly is some hemorrhage around the kidney, but not a large volume. One of the things that we see here is that after we do an ablation, the tumor often contains coagulative necrosis, and as Dr. Childs mentioned, will be hyperdense on non-contrast CT, and that's important to get a new baseline scan to avoid misinterpreting that as possibly areas of enhancement after you give contrast. Can you just run through those for me, please? Okay. This is our new non-contrast scan, and as we go through this, there is some hemorrhage medial to the kidney and cephalad to the kidney, but it's a small volume. And basically, I just wanted to make sure that we had scanned the entire kidney. You can faintly see the brighter material is blood, and there's some gas that's produced by this procedure. The goal in this procedure really, ideally, was to destroy all three tumors. The two tiny ones are difficult to see, and we may need to do retreatment on those in the future if they grow. The larger tumor was our main target to destroy because it was reaching the size where there is potential for metastatic disease, which is about a 3 centimeter threshold when the likelihood of metastases goes up substantially. So now we're positioning the patient and setting up the scan to do the contrast infusion, which we're getting ready to start. And we just used standard parameters for this. It's not uncommon to see bleeding and even some active bleeding immediately after the ablation, but this virtually always subsides with time, and we monitor these patients in the hospital for 5 or 6 hours afterwards, and monitor their blood counts as well as their vital signs. And if there's any question of instability, we would keep them overnight. So we're now doing the contrast infusion. She's much more comfortable now that the ablation is finished.
While we're waiting that, I'll address an interesting question that came in. A viewer asked, what happens to the tumor cells that have been ablated? I know they are dead, but how are they removed, or does the body resorb them? Basically, we're causing desiccation to a lot of the tissue, basically removing every bit of water from it. You can almost, in simple terms, think of it as like a charcoal briquette that sits in the tumor bed. So there's devitalized tissue that's there, and over time it will often shrink down. There will often be a little, basically a small ball, for lack of a better term, of devitalized tissue. And we can see that in follow-up imaging. We just want to make sure it's not growing or showing any signs of contrast enhancement. But it will basically sit there and not really cause any harm.
Taking a breath and hold it.
Okay, so now the scanner has initiated, and we're doing a set of CT scans.
You can breathe.
And then we'll wait about 50 seconds and do a second run through the kidney during more nephrogram phase. Could you run through those for? Janet, could you run through those numbers, or you need to? Okay. Okay, go slower again. Okay, so now we're working from top down. Go down, go down, go down. Okay, and that was the area of the tiny upper pole tumor. There you can see the tract that's been cooked. Second tumor may have been a little bit more deeper than where I was, but the larger tumor looks like it's completely devitalized. There's a small amount of subcapsular hematoma.
Taking a breath and hold it.
The pre-procedure imaging, contrast imaging, becomes quite important. We have to carefully correlate the findings from the pre-procedure to the post-procedure to decide that we've got adequate ablation margins.
So this contrast hand study is the critical part to determine whether the tumor has been completely ablated or not. Okay, now can you make this? So I don't know if the audience, can they see these scans?
Yes.
Okay, go back down from the top down. Okay, spleen, we're up into getting into the kidney now. It looks to me like the smallest tumor was ablated. Second tumor, go back a little bit, go back, keep going, go back. Okay, go back down. Down again. Okay, all the way down. Okay, now we're going to look at the littlest. Okay, now come back up. And the last tumor, the largest one, was medially located. And it was avidly enhancing on the pre-procedure scans, right in that area where the ablation has been complete. This looks like a very good result. Okay, come back up. And I think, come back up. Come back up. I think this is going to be the place where we finish this procedure. It looks like there's, at this point, no definite or really no evidence of residual viable tumor. So this patient will be monitored closely. In about 1 month, I'm going to come back. Can you go back down through the scans? We'll show the tumor on the other side. She has a left-sided kidney tumor. You come to that. It's medially located right there. And that's what the tumor should look like. And, of course, we see nothing like that in this right kidney. But that tumor is very close to her ureter, and this will be treated with the addition of a ureteral stent. But at this point, we're going to stop sedation with this patient and transfer her to a room in the hospital where she'll be monitored by nursing, given routine analgesics, usually Percocet, which is a acetaminophen synthetic opioid agent, combined with morphine if necessary intravenously for breakthrough pain. Patients are often somewhat nauseated for a couple of hours after this procedure, largely from the sedation. They have flank pain, but usually several hours after the procedure, these symptoms subside rapidly and they can resume normal activities. Meanwhile, they can they're able to get out of bed, ambulate, and get back to normal. And generally, patients are discharged the same day of the procedure. This is, for renal tumors, is generally easily done with conscious sedation. This patient experienced some pain, but she tolerated the procedure reasonably well and is resting very comfortably at this point. So we're finished with the procedure. I don't know if we want to wrap it up with this, or are there
Yeah,
any
I'll
more
just
questions?
let me. We'll address one more question here that raises a good point from one of our viewers today. States that I had to have a kidney tumor taken out, a kidney taken out for a tumor. Now they've discovered one in my other kidney. If it is small and can be treated with RFA, how do you check to be sure another tumor doesn't develop in the kidney left behind? This raises an interesting point. As this patient today, what we're seeing, and often patients have, is they present with multifocal tumors. And it's not really practical to take out all of the kidney parenchyma to remove the tumors. That would force the patient to then go on hemodialysis, which has a lot of morbidities associated with it as well. So oftentimes we see patients who had one kidney taken out, that's called a nephrectomy, and they've come back with a tumor in their other kidney. This is well suited in that situation because we only destroy a small amount of normal kidney so that we can maintain their kidney function without forcing those patients to go on to hemodialysis. That being said, as far as following these up and checking for other tumors, we do a routine surveillance after these patients undergo RFA. We typically do a MRI or a CAT scan, depending on the patient, at 2 to 3 months after the ablation. And then we do scans at 6-month intervals for a period of about 2 years. What we found of the people that we've treated is that we typically are going to see the recurrence within a year if it occurs. But nonetheless, to be safe, we follow those patients out 2 years. And if they look okay at that point, then we follow them yearly. And we're not just looking at the ablation site, we're also looking at other areas in the abdomen to make sure there's no sign of tumor spread to lymph nodes or to other organs, and as well as the other kidney to make sure that there's been no interval development of renal cell carcinomas. So
Maddie,
that basically
during the procedure.
takes
Yep.
care of our follow-up plan for these patients. The patient is starting to wake up at this point. Most patients are fairly drowsy from the anesthetic as they come around. By the time we get them onto a stretcher to the recovery area, they're kind of waking up. And then once they are stable, they are transferred over to our day hospital where they go undergo observation over the day and any nausea and pain medicines as needed. And most patients are able to go home either late in the afternoon or early evening.
Did I lose my mic?
How'd it go? Any bleeding or?
No, you did beautifully. There's a little bit of bleeding around your kidney, but just a normal amount, nothing excessive. Looks beautiful. The kidneys look like they're all ablated adequately. You did beautifully.
Oh, good.
You should be back to normal.
I'm sorry I went to sleep on you.
All right, so at this point, we'd like to thank everyone here at Wake Forest University, our support staff. We'd like to thank our production team here today, helping us bring this broadcast to you at home. If anyone's interested or would like any more information, they can contact us through our website or contact our interventional radiology clinic here at Wake Forest University Baptist Medical Center. So on behalf of myself and Dr. Zagori, I'd like to thank you for joining us today and wish you a good day.
Thank you very much.
Thank you for watching this radio frequency ablation of a kidney tumor live from Wake Forest University Baptist Medical Center in Winston-Salem, North Carolina. OR Live makes it easy for you to learn more. Just click on the Request Information button on your webcast screen and open the door to informed medical care.